Welcome to the Introverted Doctor podcast, dedicated to uncovering myths, mistakes, and misconceptions that hold healthcare professionals back from having better interpersonal relationships with their patients and colleagues. In each episode, we focus on different aspects of a doctor's professional life, such as communication techniques, mindset, routines, habits, and behaviors, with the goal to show how to eliminate anxiety, trip-ups, and unwelcome results that come from ineffective communications. I'll reveal research routines and have guests in future podcasts that will help shine light on a particular topic. I'll also have some take-home summary tips you can apply right away to start living a fuller life at work, home, and play. I'm your host, Dr. Lalit Chawla, and this episode is the third part of the three-part series on how to use frameworks and to create an optimal interaction with your patients to keep you on track, especially when things are tricky or you're feeling the pressure to communicate effectively with your patients. In this podcast, I'll talk about the conclusion of the interview and how do we wrap up so that we feel good about what we did, the patient is happier with the interaction, and everyone is clear about what needs to happen in the next aspect of the shared care approach. The show notes can be found on the website, theintroverteddoctor.com. In the past two podcasts, I've talked about the introduction and the middle. I've talked about how to get things going in the doctor-patient journey and then establishing where the journey goes. But the conclusion is to make sure that we end up where we want it to go and really clarify final expectations and questions. I have to confess, the conclusion is one of the things I can tend to forget, and I know many doctors forget this too. This happens for many reasons. I think one aspect is that they feel the most important part of the visit is to, quote, solve the problem, unquote. And more often than not, doctors have a lot on their plate and they're really trying to maximize every minute in their workday. And sometimes we think the patient got the core information. So then we can move on to the next task or the next patient, phone call, or document that patient encounter. But in terms of making a better connection with the patient, and also to prevent any personal anxieties or clarifying in your mind about what just happened next, it's really important to summarize the whole discussion clearly. Not only for them, but for yourself, so that you are crystal clear about what just happened. Because I don't know about you, have you ever walked away or later thought, did I tell them to do XYZ? Did I order that test? I should have told them to do this. So we end up second guessing ourselves or remembering things later. I know I've had to call patients back and review something with them, or ask one of the nurses to call them back to do something, or tell them something that I missed. So sometimes trying to save time adds time later, not to mention stress. So one of my mentors in medical school, Dr. Talbot, said in his opening welcoming speech when I first entered medical school at the University of Alberta, I'll never forget this. He said, fast is slow and slow is fast. Meaning, sometimes trying to be efficient is inefficient. And so often than not, taking that extra few seconds in a minute saves us so much more time and gets rid of anxieties and unnecessary work. The simple phrase I use with the patient, once I think I've gathered all the information from them, is, so I just want to make sure that I understand things correctly, and please correct me if I've left anything important out. And then I start to summarize what I think I've heard. So, for example, if I understand you correctly, you've had a cough which started 10 days ago, then it became more productive 4 days ago, and in the last 2 days, you've developed a fever and your cough has been getting worse, but you haven't had any nausea, vomiting, or diarrhea. Is that correct? So in summarizing the history, it lets them know that you've heard them correctly, and it also creates clarity in your own mind, and especially when you have to write it down or dictate it in your notes. This really applies when the clinical story is complicated and you need to clarify in your own mind what's happening in better terms. It also gives them time to say things like, actually, I've been having severe crushing chest pain, which started last night, and I'm short of breath. And did I mention that I was on a 14-hour flight overseas 2 days ago? That totally changes the diagnosis or the potential diagnosis. That extra information that they give can come up at the end, and it's not because the patient is intentionally leaving it out. It's simply that they just had more time to think about it. And also you're reflecting the clinical picture back to them, and it lets them hear it for the first time from a different perspective. Just to be clear, this part that I'm talking about is the conclusion we get once we get the history from the patient. And this mini conclusion comes early in the interview or conversation. In this part, it's also useful to clarify what their expectations are too. I can't tell you how many times I went through the whole process and didn't take the time to listen to them carefully in the beginning, and then realize they actually were feeling well now, and all they wanted was a doctor's note because their employer needed it so they could return to work. So I'm going through the whole history and doing the physical and asking them questions about their illness, but really all they wanted was a doctor's note. They have recovered and didn't need anything else, but the employer needed it so that they could return to work. So ask the open-ended question, so what brings you in today, is extremely helpful, and probably is the number one question I ask if there's not a clear reason why they are in. In other words, it's not a follow-up visit. And so anyway, I've kind of jumped off track, but I think it's really important to mention it. So the big final conclusion, in other words, after you've done the history and the physical, is to summarize what your assessment is and what's going to happen next. Whether you recommend medication or doing further investigations, it's also useful to ask them if there are any questions or concerns they may have, or do you feel that we've covered everything we need to today? This is important for 3 reasons. 1, it shows you're genuinely interested in everything they have to say. 2nd, you are clear about the next steps of the plan you've created together. This in turn makes better connection with the patient. This also is the time when people bring up the hidden concerns that they may have been really too shy to talk about earlier, such as they may be worried about a potential cancer because of the symptoms they had or a lesion they had. That question opens up the clinical conversation door further so that they can say what's on their mind. You've essentially given them permission to share again. And the 3rd reason is that you also feel satisfied that things went as well as you could have set up. It's not always possible to please everyone, but you've created a process that's clear in your mind, and you know you can go home and sleep better at night because of that you followed a well-organized framework in your busy day. Now, what do you do if they say, I have 5 other things in addition to the last 4 things we addressed? So barring the fact that if one of those other things is not a medical emergency like crushing chest pain, severe depression, or suicidal ideations, I'll say to them, Unfortunately, I can't deal with all those issues today. It's not the ideal situation. And just out of respect for the other patients in the waiting room, I don't want to keep them waiting any longer than they were scheduled to. Can we revisit this at another time? And the people are very accommodating. They can understand this. And, keeping in mind, unless it's something severe that you need to deal with right away, and usually that has never really come up. You usually figure it out very early in the clinical interview. I'll do another podcast on how to triage and deal with big grocery list of items that patients come in with, and how you can navigate that in a respectful manner. But staying on the core theme of conclusion in this framework, I want to talk a little bit more about discharge instructions. Giving proper discharge instructions may seem simple enough to do, but so often what we think sounds right or clear in our mind is not necessarily what is heard by the recipient, especially if there's a language barrier, hearing difficulty, or they're cognitively challenged. Here's a true story I heard from a CMPA, which is the Canadian Medical Protective Association Education Center. And this happened to an exceptionally good ER doctor who was working in a pediatric hospital. Well, the situation was that a couple brought in their little toddler baby into the ER because the child had been having vomiting and diarrhea for a few days. The doctor appropriately assessed the child, initiated some treatment for mild dehydration, and then gave the parents some advice on how to keep the child hydrated. He said something to the effect, if nothing changes, then bring your child back for reassessment. Well, the child continued to have vomiting and diarrhea, and nothing did change as far as the parents were concerned. Their child was still vomiting and having diarrhea. So they didn't bring the child back for reevaluation, and unfortunately, the child died from dehydration. The ER doctor was found negligent for not giving proper discharge instructions. Now, keep in mind, this was not a bad ER doctor. He was, for the most part, excellent at his job, and he had saved so many children's lives. But unfortunately, we hear about these cases because they're so tragic. But it's, this one case that had a tragic ending, and it's unfortunate for so many reasons. But I always tell medical residents and medical students this story, and the lesson being is that it's important to be clear and aware about the language that you're using. In hindsight, a better way in this case would have been to be more specific about the discharge instructions. So he might have said, if the child continues to have vomiting, diarrhea, or fever, or is not peeing, you should bring him back in the next 12 to 24 hours. If you notice any new symptoms, please don't hesitate to bring the child back for reassessment. He looks fine now, but he should be getting better in the next 12 to 24 hours. So if he doesn't, bring him back. Or if you're concerned, please bring him back. So that might be one way to say it. Because if there's anything I've learned over the years in medicine is that people can be fine when you last saw them, but things can change. And outlining a proper discharge plan is crucial. I'd rather be extra clear than less clear. I simply tell the patient, I'm telling you all this because this is just simply part of good discharge instructions. I'm not trying to scare you, but I just want to be clear about possible outcomes. Another tip is write it down and give it to them. People, especially parents, elderly patients, they're worried and have so much on their mind, and they don't know necessarily or hear everything that happens in the clinical setting. And we as clinicians, we might know the dose of acetaminophen or Tylenol. Or ibuprofen, acetaminophen, same thing. Because we've done it for years and we've calculated it frequently in the week. But for them, that may be the very first time they may be hearing that information. So in summary, having a proper conclusion helps not only the patient, but also it helps ourselves in so many ways. Here are the key points from this episode. Number 1, summarize the visit as you understand it and ask the patient if there's anything else they would like to add. Number 2, if you can't address all their issues today, don't be afraid to ask them to reschedule and prioritize depending on the appropriateness of the issue. Number 3, clarify what they're expecting from the clinical visit today. Number 4, give proper discharge instructions in a language that they can clearly understand. Keep it simple and don't use medical or fancy words. When people are not well, they don't hear everything clearly. And finally, number 5, write down any instructions for them. It only takes a few seconds, and remember, fast is slow and slow is fast. I hope this podcast served you in some way or served you as a reminder. You don't need to use all these strategies, but pick 1 or 2 and see if it helps. If you've enjoyed listening to this podcast, please share this with a friend or colleague and subscribe to us in iTunes, YouTube, Spotify, Google Podcast, or your favorite podcast app. And please don't forget to leave a rating. I know it seems like a small thing, but it really makes a difference in terms of helping others find this podcast. I'm Dr. Lalit Chawla, and thank you so much for listening. Let's together make a greater, more effective community and inspire people to be their best. Tell me what you liked about the podcast, what you'd like to hear in the future. Have a great day and a great week.